First of all, I would like to thank Professor Tenica for his kind invitation to this conference. And I am very happy to be with you again in Romania, the country which I have prepared my specialty with all my colleagues and my professors in Romania. Now I'm working in Italy and in Syria, and we have had a very nice experience about the complex congenital heart diseases to transmit this specialty to developing countries. Thanks also the authorities and everything for this nice organization. Complex congenital heart diseases management is really a challenge for developing countries. We know everybody that the congenital heart diseases is the first cause of death among the congenital diseases. In 1970s, the infection disease was the first mortality for the children in infancy. And in 2000, perinatal diseases 69%, and congenital heart disease is 30%. Congenital heart diseases in developing countries is 2 to 6 million of children with congenital heart diseases waiting for surgery. From half and one of 1.5 million new cases every year. Congenital heart diseases is a world problem and priority for many countries. We know pediatric mortality, 9 million children die every year. 3,500,000 die with the first 20 days of life. This is the World Health Statistics, 2008. 260,000 neonatal deaths are caused by congenital anomalies. 130 are due to heart diseases. This is the countries where the cardiac surgery satisfies the needs. We know that in Europe it's 500 cardiac surgery centers. In Africa, with 1 billion inhabitants, we have only 50. Birth defects, more than 7-9 million of children are born every year with serious congenital disorders. The most common and serious disorders are congenital heart defects, neural tube defects, and Down syndrome. We see here the world challenge in pediatric cardiac care. In United States and Russia, Japan, and Brazil, we observe the difference between the Egypt, for example, 79 million of inhabitants. How is the situation? How many, in comparison with USA, 120 cardiac surgery center, and in Egypt it's 3. The real challenge for developing country, it's the neonatal surgery, because this is a real complex problem in our countries. Of course, the most neonatal surgery procedures are performed routinely is coarctation repair and systemic of pulmonary shunt, patent ductus of arterial closure, pulmonary artery banding, Norwood procedures, arterial switch operation, truncus arterios repair, interrupted aortic arc, total anomalous venous drainage, aortic stenosis repair, pulmonary stenosis, or atresia. Progress of neonatal surgery, it's prenatal diagnosis and postnatal diagnosis and surgical techniques and extracorporeal circulation and perioperative management and postoperative management. Neonatal cardiac risk factors. We know the newborn physiology and the extracorporeal circulation and the weight. This is an example about the difference between adult and neonate. For body weight with 75 kilograms, 3 kilograms, and blood volume with 5 liter and 200 milliliters, the extracorporeal circuit priming 3 350 milliliter, and for the neonate it's 15. Blood flow is 300 milliliter per minute, and for neonate it's 30 milliliter per minute, and ultrafiltration range about 3,000 milliliter per 24 hours. For the neonate it's 200 milliliter per 24 hours. The accuracy is 10 milliliter per minute, and for neonate it's 0.1 milliliter per minute. The newborn physiology is multi-organ immaturity: metabolic, respiratory, neurological, renal, and myocardial. Preoperative advances: fetal diagnosis, ventilatory manipulation of pulmonary vascular resistance, percutaneous and interventional procedures, and diagnostic tool, MMI and scanner, and TC scanner. The intraoperative advances is attenuation of inflammatory response and myocardial protection, and pH management and circulatory arrest versus low flow bypass and hybrid procedures. The postoperative advances is with nitric oxide, with ECMO and low cardiac output management and renal failure. Progress in cardiac surgery for extracorporeal circulation, circuit miniaturization and control inflammatory response, and hypothermic low flow and cerebral blood flow control system. The progress in and postoperative management is ventilatory techniques customized by nitric oxide and circulatory support. This is the operating room, everybody know it, how many it's complex. And the new technology, it's helped us a lot. And the hybrid surgery, it's very important. And the ventricular failure and assistance device is very important in this matter. The physiology and hematologic, immunological, and metabolic differences from the adults. We can observe the most common surgical procedures. It's arterial switch operation. It's 2,154 with 5 mortality, and coarctation with 4% mortality, and BDA, surgical closure, and BT shunt or Norwood, we can observe the 36% of mortality. And the neonatal cardiac surgery, it encompasses at least 25 of total cardiac operation in children. The fetal echo for TGA, the detection of transposition of the great arteries in fetus reduce the neonatal morbidity and mortality. Of course, the three-dimensional echo, it helps us a lot. The CT scan angiograph also. The initial therapeutic indication is for some of the complex congenital heart disease in neonate is TGA and hypoplastic left heart syndrome and total venous drainage and coarctation and aortic arc interruption, and we have some hemodynamic procedures for TGA and aortic stenosis and pulmonary stenosis with intact ventricular septum. We have the pulmonary atresia with MAPCAS. This is the hybrid procedure between surgeons and hemodynamics. Pulmonary hypertension is a real problem in neonatal children. The treatment of pulmonary hypertension is classic with hyperventilation and with oxygen. The treatment of pulmonary hypertension, the newer with nitric oxide with pulmonary vasodilatator as inhaled and ongoing studies, and limiting factor need to be intubated. Future needs prostacyclin and dipiridamole and the others. The pediatric cardiac surgery is the future to research and new technology and tissue engineering and centralization of care. The new surgical procedures for hypoplastic left ventricular heart and aortic valve diseases, and TGA and pulmonary atresia. The pediatric cardiac mortality relationship between the patient volume and outcome. The both annual surgeons volume and annual hospital volume are inversely correlated with mortality rate. We can observe that between the difference between centers above than 350 cases per year, it's 8% mortality, and the low volume centers less than 350 cases, mortality is above 14%. The newborn heart surgery in 2001, it was 11%. And of course, here we can see the difference between 1960 for cardiac surgery and 2000. In this, we can observe that from 1970 to for neonatal cardiac surgery, the difference in 50 years. This is a problem. We can do that what the developing country done in 15 years, in developing country, we can do them in 5 years or 6 years. This is with the help of the expert and all the modern centers. The neonatal cardiac surgery centers, in the conclusion, we should be it should be a national project in order to reduce the cost and to rationalize the human resources and improve the results. And in this organization should expect the require that surgery be performed well-organized center, and to be sent in regional centers could establish as a geography, population, and resources dictate. The multilateral cooperation is very important to join experience and human resources and join economic resources and guarantee the sustainability and offer frequent presence and measure impact of educational program. It needs the authorities, the professors and the experts, and to select the good candidates, to teaching everybody, and work team between the different places. It's the minimal solution is to create 3 types of the clinical and diagnostic cardiology unit. This is the type A. The second is intermediate solution, is clinical diagnostic and interventional cardiology unit, and full solution cardiac center and division for cardiology and cardiac surgery. This is the basic solution. This is, I would like to present the Associazione Bambini Cardiopatici nel Mondo, some of her activity, because it's an ideal organ to represent this cooperation and develop this in this process in developing for complex congenital heart diseases. The presence of association in all of the world, and they have done a lot of work. Ongoing project in Egypt, Syria, Cameroon, Kurdistan, Ethiopia, Peru, Kosovo, and Tunisia. In Egypt, the mortality was very high, and it was impossible to do babies under 2 years, and they create a new intensive care unit. This is very important to have a very, very important intensive care unit in this type of diseases. This is also a new operating room for in Egypt. Also, they brought the instrument equipment. In Cameroon, of course, we have a very, very important project. We have started the collaboration with Cameroon, and in a lake with 500 million of inhabitants, it's only one center to do such operation in a very important project. This is operating room, And this is the training, the team in the education program, and the team with 6 doctors and 10 nurses with 2 perfusionists and 1 administrator. Also in the north of Iraq, we have a very important activity, and now we have a good team was prepared and to be sent again in Iraq to continue the work. In Ethiopia also, in Peru, it was an ideal experience to realize what we have talked. This is the intensive care unit before, this is what the intensive care after. And what we have talked about the secondary and the primary solutions, with a huge country, we can do that because in Iquitos and Cusco and Arequipa, it was impossible to put a diagnosis for children with this malformation. This is an example. For example, we create a place to do this, an echograph in one of these cities. This is in Kosovo. Also in Tunisia, we donate this intensive care unit with Canaria also, and in Damascus, it was the biggest project which we have done from the zero in Pediatric University Hospital, and they donate the hospital in 2006, and it was very nice experience. This is operating room. This is it was a closed circuit to go to from the operating room to the intensive care unit, the post-intensive care unit. In Syria, population has 22 million, with population under 50% under 15 years. 9,000 congenital cases in Syria, and 4,000 in congenital heart diseases. The pediatric cardiac surgery in University Cardiac Center, we do 700 cases. In another 3 hospitals, about 600. Of course, pediatric cardiology department is with echo lab and cardiac catheterization. And the cardiac surgery department, we reach, it's 85% we do, and complex 20%. The morbidity as infection diseases and bleeding and neurological problem and renal dysfunction and respiratory disorders, as we have mentioned before. Mortality, we succeed to reduce the mortality in simple pathology until 3%, and the complex pathology from 90% to 20%. This is what we have, the plan of developing in Syria, the Pediatric Cardiac Surgery Center, in Aleppo to do 500 cases, and in Latakia 400, in Homs 300, and the new Pediatric Cardiology Unit. Thank you, everybody.
Thank you, Dr. Tammam, for the excellent presentation, and now the paper is open for discussions. Dacă doriți să puneți întrebări.
Professor Tammam is working also, he was working in Syria, now he's waiting for better time. I have a question. One of the major problems in the developing countries are the sustainability of the center. You can create a center, you can start, but if you don't ensure the continuity, you risk to lose all what you have done. Which is your experience in Syria?
Of course, in Syria, it was very nice cooperation between Italy and Syria, and we create the new pediatric cardiac surgery center with a condition from the Italian government and from Associazione Bambini Cardiopatici nel Mondo that the authorities they should finance this project and for training program. And they sustain fully this center, and in these very hard conditions they are still working, but I mean it's very important. Of course, in Syria we have had a very Now it's a bad situation, and I mean it's very difficult situation, but they still operate and they still working with the same level, with the same. They give materials and they are working until now. Of course, in Syria, the pediatric cardiac surgery in developing country is a culture, because everybody knows that it's 10 or 15 persons they must do, and they must work together. One of them, if it's not good, it's compromise the surgery. I have a very, very hard experience to stay hours and days without to sleep and to stay with beside baby until the people. In 6 years, we reach a very, very nice experience, and I mean, it's an example to be done in everywhere. But without human resources, you can't do nothing.
Yes, but my question also was, how can you ensure the sustainability? The government is in favor, is pushing, is collaborating?
The government, they are collaborating, they are pushing, they are sustaining all the activity, and they help. I mean, exactly as in Italy. It's very important to know that in Syria we do 250 cases interventional cardiology, including ASD closure, PDA closure, and this is, you know, that it's very expensive, this kind of devices, but we do them with a very good results. Also, we have the best material with oxygenating for the neonate, and all the expensive antibiotics, and even in the new center, we use a laminar flow, a very high technology. We reduced a lot the use of antibiotics there. But I mean, they give us all what we need. And of course, without the sustainability of the government, you can't do nothing.
Of course. I want to ask you, we all know that there is a good tradition in Syria with a good tradition, I mean, in cardiovascular surgery. There is, we all know that in Damascus is a very good center of cardiovascular surgery. But of course, I understand from you that the government made this national plan of developing pediatric cardiovascular surgery. And I wanted to ask you, so you are involved in this plan. I want to ask you, how was the plan for human resources? You trained a part of the human resources, I mean cardiologists, surgeons, anesthesiologists in Syria and in Italy, or only in Italy?
Yes.
Or
yes.
Both? How did you do this?
We have had a very nice opportunity to have a chief with is in United States training, and he was very open mentality, Professor Sami Kabbani, and he was collaborating with us with a long way which we have worked. It started in 1994. And we reached the results in 2006 and 2007. Of course, they came in San Donato, much more than 25 persons. And we have had a lot of surgeons and anesthesiologists in France and in Germany. And they came back, and for this reason, but I mean the mainly collaboration was with Associazione Bambini Cardiopatici. We have done much more than 25 missions in Syria, because teaching in loco is very important. Because when you go to 3 or 4 patients, they can teach 30, 40 persons there in the same place, and to arrive to reduce the expenses. I mean, but we have a lot of nurses which they came in San Donato, a lot of doctors which they came in San Donato, and they came back and worked there.
Sì, ma Professor Tammam, the question of Professor Suciu is, you trained abroad, but do you train also Syrian doctors and nurses in Damascus?
Of course.
Okay. this is
training in
important
loco. This is
answer,
training in
important
loco.
question.
I
mean, this center
four...
becomes a reference center for educational training in Syria.
Yes, of course. This is the most important. That I left Syria. I left Syria from 8 months. They are working there, 3 doctors, the same results, the same work, without any problems. This is what we have done, and it will be an educational center. Of course, this is it was our one from our aims in this center.
Yes, that's what I mean. So it's important to have a national, at least national reference center, and to contribute to developing human resources.
Yes, and for all area.
Okay, thank you, Professor Tammam.
I would like also to thank Professor Socotiano, because he was one of my teachers, and Professor Bersan, which I was growing
Ringraziali in rumeno.
Mulțumesc foarte mult din inima lui domn profesor Bersan și profesor Socotiano, că eu am, să zicem, chirurgia cardiacă am făcut-o la dânsii și ceea ce am făcut în Italia era numai un pic de perfecționamento și deci experiența cea reală era în România la centru de la Funden cu domn profesor Bob de Popa, care care îl cunoașteți toți și care acum centru este cu directorul Vlad Eliescu, care eram colegi și am lucrat împreună și a fost o foarte frumoasă experiență care era indimenticabilă, de neuitat. Vă mulțumesc foarte mult.